I think excellent. Dr. Faisal, are you ready? Have you?
Yes, I'm going to try to share my screen now. Can you see my screen now?
Yes, we can see it now. Please go ahead.
Okay, great. Okay, thank you very much again, Pakistan Live, for giving me this opportunity to talk about maintaining morale and preventing burnout. It's a difficult act to follow, Dr. Park, but I'm going to try. Essentially, I think as Dr. Park has alluded to, we are our field is tough. Being a physician itself is tough, but being a cardiologist and then an interventional cardiologist is even tougher. We take STEMI call. We are many times we haven't slept for 36 hours, and it's exhausting. And many times we lose patients. Patients have complications. Every single bleed that happens, every single creatinine that goes up after a cath is exhausting, is mentally exhausting. So we suffer from emotional exhaustion, depersonalization. There may be a couple of days where you have two complications in a row when you're on call, and it kind of makes you depressed almost. So what works in what helps us is the confidence, is the enthusiasm, and that is where the balance kind of becomes difficult to achieve. Why is this burnout on the rise in the cath lab? I think in the post-COVID era, especially, there has been a lot of changes that have happened in our lives, which none of which was done by us. We may feel not valued by our organization. In the US healthcare system, many times, actually, even though we are interventional cardiologists, sometimes some of us were asked to do internal medicine work. Some were, we sometimes we may feel like we are not being valued by the organization, increasingly being measured. My previous talk was about NCDR. So, you're being measured on what are your complications, how many cases you're doing, are you able to do 50 PCIs a year or not, and so on and so forth. There are complex regulatory requirements. There is a high turnover of staff. Every time one of your experienced cath lab nurse or cath lab staff, technologists leave, you have to train somebody new. Now, if you're doing a difficult case and they lose the wire, that is difficult to handle, many times, and it increases mental stress. Many times our work hours are unpredictable. The call burden can be unpredictable as well. So in this survey, as of the physicians as anchors of the team, they surveyed about 15,000 physicians across 29 specialties, and it was found that about 43% of cardiology physicians felt that they were affected by burnout. It increases with age, and due to factors alluded to by Dr. Park, the rates are slightly higher in women, but they are not much lower in men. From some of the research that has been done in this area, a meta-analysis looked at 15 randomized controlled trials and 37 cohort studies, and overall burnout rate after various interventions decreased from 54% to 44%. After using individual focused and organizational strategies that were implemented. Our cath lab staff, like nurses in the US particularly, and I'm sure it's the same in Pakistan, that they also suffer from burnout. In this survey of American Nurses Association, 1 in 3 nurses felt that they had inadequate staffing levels. About half of them felt that they have excessive workload and not being much appreciated. So it is not only in physicians, but among the cath lab staff also. What are the strategies to build morale? And that is basically encourage team innovation. Do something exciting. Maybe bring a new device sometimes. And when you have your staff doing an in-service, they can have some snacks to eat at the same time, and that might help build some morale. Don't be a negative person. Don't talk about negative things all the time. And a flow of positivity around a person actually makes them a morale booster rather than a morale extinguisher. Fix the problems, don't cover them. Truly, team building activities should be encouraged. Have a unified mission. Use email appropriately. Many times the emails, particularly, may not be the best way to communicate, can be very inflammatory and can be offensive and can be taken out of context. So therefore, face-to-face talk is important in this era of social media and email and online activities. It is important to promote the camaraderie. Attending staff recognize the team. It is generally my practice to recognize every member of the team at the end of a case. I tell them, thank you, John, thank you, David, at the end of the case, thank you, Marissa. That is very well appreciated by the staff, because many times, the staff may not feel appreciated. Real examples of things that have been done, holiday lunches, get together outside of work, have some dinner or lunch or snacks, things like that. Common scenarios leading to burnout and low morale include frequently asking staff to do stuff that they are, first of all, not proficient in doing. You ask a non-structural trained staff to do a TAVR with you. That can lead to burnout. Asking the staff frequently to stay on to complete add-on cases, because unpredictability in schedule is stressful. Like Dr. Park alluded to, have a plan ahead of time. If you in 2 months, if you have a vacation coming up that you know of, that actually would help the morale and decrease the chance of burnout. Other things that can be done are tracking the frequency of keeping staff late. If every day you're having to ask people ad hoc that, today, Mariam, you have to stay late until 9 o'clock because we have 2 more cases to do, that can be a problem. And therefore, maybe having a backup team to minimize unpredictability. If you're on the backup team and you know that you can be called to stay, that might be better it may have a better acceptability compared to asking somebody at 4 o'clock that you have to stay till 10 o'clock. Can be very demoralizing. Mandate physicians to prioritize and sequentially perform cases so that you don't have the most important case of the day to be done at 8 p.m. Basically, if there is a patient with acute coronary syndrome, I think those patients should be prioritized. And so on and so forth. Staffing cases with extending procedures, the staff should be well trained. Unfamiliarity with the procedures is stressful. Knowing the patient needs, room setup, patient preparation, locating the equipment where that is. If you have a wire that you think you're going to need, have it in the room available before the case. And then educational activities, like I alluded to, basically attending meetings like this for the staff actually would be very helpful in addition to physicians. Financial support to come to these meetings would be helpful. Organization of equipment. If you're doing a chronic total occlusion case or you're doing a TAVR case and you know that you may need to a balloon angioplasty and iliac artery on the way up, then have that equipment available in the hybrid OR instead of going downstairs or upstairs to the cath lab to get that when the need arises. Dealing with errors, bad outcomes, and heart-wrenching cases. So when a complication happens, a patient expires on the table, it is important for the cardiologist as the team leader to talk to your team, because losing a patient or having a major complication can be very stressful on everybody, not only on you as a physician, but also on the staff. So it is important to talk to them. And of course, talk to your family, and then taking care of yourself as well, because as a physician, you may be getting burnt out as well. So maybe talk to your colleagues talk to any other resource that is available from the administration, human resource that might help get over that problem. And in a society like the United States, where there is a lot of litigation, it is important to involve risk management also when a complication happens, because there is a chance of getting sued. When a death happens in the lab, maybe a moment of silence or a moment of prayer might be helpful for all the staff to get over that adverse outcome, would be helpful for everybody. So in conclusion, burnout is common among interventional cardiologists, among the staff, and should be acknowledged. First step is to acknowledge it, that, don't be stoic. Don't feel like that you cannot acknowledge that you are tired or burnt out. Many circumstances in the cath lab can affect morale, and recognize those circumstances and try to have strategies how to tackle those. Strategies to combat burnout and low morale exist. Camaraderie and meeting the staff and physicians outside of work is very helpful and healthy. And having a healthy cath lab environment takes work, is important, and hopefully would help in a long interventional cardiology career, both for the staff and for the physicians. Thank you very much for your attention.
Thank you, Faisal. Great, great, I guess, points for all of us to try to follow and see how we can prevent ourselves. Despite all these talks, I think when we start working, then we forget about all other things. And I think I was just looking at a survey recently from one of the organizations, and they had rated the burnouts in terms of specialties. And actually cardiologists, I don't know whether how many interventional cardiologists or cardiologists were there, they actually lie lower down. There are other specialties who have more burnout than cardiologists. But I think interventional cardiologists who have a lot of other responsibilities, administrative, research and everything, their burnout, I'm sure, is there, and these things will definitely help.